Okay, madam, thank you very much. Good morning, friends, senior members, friends and colleagues. It's a great honor and privilege for me to stand before you for giving this Dr.R.V.Rajam Memorial Oration. My talk is basically on the recent trends on the molecular imaging. I'll be confining myself to the practice of the neurology, that is the brain, and basically, before I start my talk, let us pay our tribute and the fond remembrance. As Madam has already said, Dr. R.V.Rajam was a great pioneer in the field of the venerology. He was the first dean of the Madras Medical College, a very renowned medical physician from the southern part of the country. So friends, molecular imaging is a very new subject in the medical sciences. It is being practiced in our country for the last about 5 to 7 with the emergence of the new technologies. So before I share my experiences at my institute, where we are practicing molecular medicine from bench to bedside in a variety of the clinical disorder, let me set the motion to tell my younger colleague what is molecular imaging. The molecular imaging is the in vivo imaging of the spatio-temporal distribution of molecular and cellular process. To understand it in a much better way, when we want to image these molecular or physiological process in the cellular environment or a tissue environment, what is required to be done? We have to know about, there are basic 3 things involved in the molecular imaging. One is the metabolic imaging, blood flow imaging, and the imaging of the various receptors which are located in the extracellular compartment and on the cell membrane and the intracellular compartment. We have a variety of the receptors located in the extracellular imaging for like peptide imaging. We have got a variety of the receptors in the outer surface of the cell membrane or in the intracellular cytoplasm, which are responsible for a variety of the function like glucose uptake, like the protein synthesis, the amino acid transportation, and apoptosis, hypoxia. A variety of the receptors are available here. I will not go into the detail. So the basic question in the molecular imaging, how to target these receptors so as to elucidate the various physiological and metabolic processes which are going within the body system, thus enabling the detection of a abnormal physiology in a variety of the disorder which I am going to illustrate in due course of time. So to target these receptors, we have to have the molecular probes. So what are the molecular probes? The molecular probes are, in the recent time, we have a variety of technologies like positron emission tomography, SPECT, CT, MRI, and the optical imaging is in a very nascent stage of development. And now the hybrid imaging is coming. I am sure majority of you will be aware, like PET-CT, PET-MR has already started coming. So we are trying to exploit these with the help of these molecular probes, the various physiological processes, and target them in the various stages for because of the various metabolites. And these metabolic probes, how they go to the target, is very, very important to know. We combine them, we conjugate them with a variety of the biomolecules and then facilitate their entry into the cellular or the extracellular compartment. So it is basically a very team effort where the imagologists, the radiopharmaceutical chemistry, the physicists, a variety of the people are involved to give the end outcome to the molecular imaging. Then we have got a variety of technologies, the advanced imaging tools at our disposal, like we have got a PET-CT, PET-MR is also coming in a country, and the SPECT, the poor man's PET, and the MR also can also play some role in the molecular imaging. Then we get the spatial distribution of the various metabolites, like glucose, for example. What is the glucose utilization? What is the differential glucose utilization by the various parts of the brain can also be seen by these techniques, so as we can know, because glucose metabolism or the bioenergetics of the cell is a very, very important tool to find out, to detect the disease processes in very, very early ways. So this is the nutshell what is molecular imaging. Just to give you an example, we have got the several molecules or the atoms like carbon, nitrogen, oxygen, and chlorine. This is just I given you a very diagram to understand. Like you want to start the metabolism of tyrosine to the epinephrine. What are the different metabolites at the different level? They can be targeted by the molecular imaging. At the moment in our country, only the fluorine 18 is being used like the FDG PET. We are, I'm sure majority of the people are aware. But in our institute, beside the FDG PET, we are going to have a lot of other molecules based on the carbon 11. We are also trying to do the oxygen utilization, O15 utilization, and the nitrogen also. B stands for the boron, C for the carbon, and for nitrogen, oxygen, chlorine. So by this we can depict the disease process at a very, very early age. The aim of the imaging is the early diagnosis of any disorder, and then the delineation, extent, and the therapeutic intervention, monitoring of the responses. These are the expectation of the clinician from the imagologist. The molecular imaging is going to play a very, very important role in this area. So friends, now coming to the subject proper, where we have been doing for last 3 to 4 years in my institute, which is the Ministry of Defense R&D organization. We were the first to bring the MR in the country way back in 1984. Now we have a very dedicated molecular imaging center where we are practicing molecule to the bench to bedside. We have we are generating all kinds of the molecular probes at our institute and trying them in the various clinical conditions. So just in this next half an hour or so, we have our own experience in the field of dementia, movement disorders, and the brain tumors. In the dementia, we have basically used the fluorodeoxyglucose, and it is a very, very important role, play a very important role in the mild cognitive impairment, Alzheimer's, and a variety of other conditions which have dementia and all that. So we are trying to do the qualitative distribution of the metabolite as well as the semi-quantitative, because the quantitation of these metabolites is very, very important. In the imaging technologies, this is an area where everybody is working how to quantify a metabolite so as to attribute that metabolite for a disease condition. Movement disorders also we have tried with the fluorodeoxyglucose, but we also have tried the F-DOPA, which is the dopaminergic pathways. I'll give you some example like a movement disorder like Parkinson's disease or Parkinsonian type of syndrome, which is a complex where there is movement disorder associated with dementia and so on. So how these are utilized, what is the differential metabolism, and how they help and facilitate each other, whether merit and demerit. In the brain tumors, which is a very, very early diagnosis, and the recurrence after this surgery is a very, very important diagnostic aim of the imagologist. Beside FDG, we have a variety of the isotopes or the radio tracers we have developed at our institute, which are targeting on the protein synthesis, which are targeting on the DNA, which are targeting on the the amino acid transportation. Like I will not go into the detail. F-DOPA, methionine, carbon methionine, FLT stands for the fluorolevothyroxine. It is one of the nucleoside found in the DNA, and beside the fluoroethyl tyrosine, FET. So these are the new radio tracers, molecular probes. They are very, very specific, very, very sensitive for the early diagnosis of the tumors, and they can also be very, very important in the post-operative cases to differentiate between the residual fibrosis and the recurrence of the tumor and so on, and monitoring of the response therapy. So with this, let me tell you something about dementia. As you all know about the dementia, it is a complex situation. We have done these cases from 318 cases we have done in all the three categories. And dementia, we have got the mild cognitive impairment, which is between aging and the dementia, one of the very, very early, where if you can diagnose these cases in the MCI stage, that is mild cognitive impairment, by the various psychological tools added by these imaging technologies, we can really help the patient in a very large extent, and because a lot of new advancements have taken place in the medical therapy, so this can be very, very useful. Now coming to the mild cognitive impairment, is an example of a patient, a 71-year-old gentleman, had the MMC score, the mini mental state scoring 24. The FDG PET, you see the differential distribution of the metabolite. This is the cortex of the gray matter of the brain. You see there is hardly any metabolite going to the mesio-temporal aspect of the brain. So this is one of the very initial signs where there is a hypometabolism of the glucose. The glucose utilization by the brain cell is very, very less in these cases. So these are the very early cases where the MCI can be picked up. Of course, the psychological, clinical psychological studies are very, very paramount importance, and so they have to be corroborated with each other. Now coming to the other cases, late Alzheimer's disease, we have some example here. You see the distribution of the FDG. You find that there is a marked hypometabolism of the frontoparietal and the temporal aspect. However, the basal ganglia, thalami, and the caudate nuclei and the globus pallidus and all that take intense glucose, and the occipital cortex is also spared. So these are the findings. These are our initial experiences which we want to share with you, and there are so many variabilities there because of the paucity of time. I will not go into the detail. Now coming to the Parkinson dementia, because majority of the cases of Parkinsonism or Parkinsonian syndrome have a dementia element, because these are all complex neurological disorders. Here you see here, if we do the normal FDG, this is being utilized in the various PET-CT centers of the country, you see there is only hypometabolism in the left frontal area. But here we have got a very selective molecular probe which is trying to tell you about the dopaminergic pathway, the presynaptic dopaminergic pathways, and telling you about the integrity of the nigrostriatal pathways. I will not go into detail. You see here, there is hardly any uptake in the cortex and the brain, but this particular isotope, there is F-dopa, dopaminergic, is going selectively into the basal ganglia region, the caudate and the globus pallidus and putamen area. You can see here, and you see that there is a slightly decreased uptake in the lower part of the posterior aspect of the basal ganglia. So I just want to emphasize and give you a carry home message. We have got the selective molecular probes now available which go to these selective sites, and you can find out the integrity of the various parts of the human brain. Now there is another case of dementia, like the progressive supranuclear palsy. This gentleman had a history of the dementia along with the nystagmus and some sort of the Parkinsonian syndrome. And you see here, when we do the MR study in this case, the MR study showed the minimal cortical atrophy in the frontoparietal region. But when we saw the FDG PET here, you see there is a hypometabolism in the areas of the midbrain, in the area of the basal ganglia, and also in the in the gyrus, in this area of the paracentral gyrus is here. And these radioactivity these are all image processing tools. The image processing tools are advancing day by day, because all the cross-sectional imaging, the image processing tools play a very, very important role. There is a statistical parametric mapping where we can quantify and delineate from where these signals are coming. You find that the hypometabolism is in the midbrain, as shown the bluish color, and the caudate nucleus, and in the areas of the anterior cingulate gyrus. So when we saw retrospectively the MR image, we found that there is a tactile atrophy. The superior colliculi are slightly decreased. So molecular imaging tells you what is the problem in the brain, where the pathological or the abnormal physiological process is going on. So friends, in the FDG PET or the molecular imaging plays a very, very important role in the dementia. It is one of the very useful metabolic marker for diagnosis of the early cognitive impairment, that is the MCI. And MCI, or the mild cognitive impairment, is a stage between the aging and the dementia. About 10 to 15% of cases of MCI, they transit into the Alzheimer's disease. So it is very, very important tool. A new compound has come which we have no experience, that is the Pittsburgh compound, carbon 11, but it has got a life of only 20 minutes. I just want to tell this August gathering that the utility of these isotopes depends upon what is the half-life. Like FDG is popular because it has got a half-life of 110 minutes. After it is made in the laboratory, from the cyclotron of their chemistry laboratory to the injection to the patient, there is some time gap. But the carbon-based compounds and some of the compounds like oxygen, they have got a very limited half-life. So you have to have these, instruments in your institution to have use them in the practice. Now coming to the movement disorders is very, very important because it can be, as I said, the aim of the molecular imaging is the early diagnosis, and secondly, the assessment of the extent of the disease and the involvement of the various neuronal pathways, and secondly, then the monitoring of the response of the therapy. We are doing some cases because, as I said, we are only 3 to 4 years old in these new radio tracers, so they can play a very, very important role, and a variety of the neurosurgical technique like deep brain stimulation is being practiced, and also the response of these therapeutic surgical techniques can also be monitored by these radio tracers. Now, as I said, you see example in case of Parkinsonism. This is the normal F-DOPA scan. As I told you earlier, the DOPA stands for the dopaminergic pathway. You see, there is hardly any uptake in the brain. It is entirely going to the basal ganglia. You see how nicely the basal ganglia have been demonstrated. This is early Parkinsonian disease, showing you some degeneration of the basal ganglia here. The activity in this part is less. You can compare it. And in the late cases of Parkinson, you see the basal ganglia uptake is markedly decreased. So the degree of the severity of the disease can be assessed if you have these selective probes. Now, multisystem atrophy. This is another kind of a very progressive neurological degenerative disorders which are associated with the dementia, Parkinsonism, and autonomic system, like they have got incontinence, they have a bowel and bladder symptoms, so variety of things. You see here, the glucose uptake is more or less normal except in the cerebellar part. In the brain, the MRI also shows marked, degenerative changes in the posterior fossa cerebellum, and F-DOPA also shows you the selective, degeneration in the basal ganglia region by showing you very decreased uptake. Besides this, there are a variety of the conditions of the dementia. They present a different form. The degenerative changes are in the different part of the brain. This is another example of the corticobasal ganglion degeneration. The molecular imaging has tried to define the etiopathogenesis of the dementia by their differential distribution of the glucose uptake. Like in this case, the MRI scan looks more or less normal, but you see here there is a decreased uptake in the posterior parietal area, and there is a decreased uptake in the left basal ganglia. Now, coming to the most important feature in the brain tumor, we have got a variety of the technologies at our disposal. MRI and the contrast MRI and so many other novel techniques of the MRI are playing very important role in the brain tumor in the preoperative and the postoperative stage, but still there are some limitations with the existing technologies. They are in the basically to find them at a very early subtle stage, find out their recurrence versus fibrosis, and find out whether the tumor is very low-grade tumors. Again, the MRI or the contrast MRI has a limitation at times in the clinical scenario. There are a number of cases, or there is a tumor which is non-enhancing, and it is not very sure whether it is a tumorous condition or it is an inflammatory condition. That is another issue. So there are so many pitfalls in the existing diagnostic tools. So how the molecular imaging can advance our knowledge and facilitate the patient treatment, as I would like to show you. Brain as such, if you see, I have beside this selective radio tracer which I have shown you like F-DOPA, brain is a very glucose avid. In a normal individual, the cortex of the brain, the gray cells of the brain, gray matter of the brain which we call, is a very glucose avid. It takes glucose in a very larger way quantities. So sometime what happens, the neoplastic lesions and the inflammatory lesions, they also take lot of glucose, so that it is very difficult. Because we want the delineation of the tumor, the extent of the tumor, because of the background activity, sometimes we are not able to decide. So how I'll show you some of the example, how the new radio tracer beside FDG, non-FDG radio tracer, which we are producing at the moment in the country, and we are giving to some of the centers, how they have helped in the diagnosis, staging, and the monitoring of the treatment response. Here is a case of, I will not go into the general, because MRI has a lot of capabilities, and PET FDG has a lot of capabilities, but there are subtle cases where the limitation still exists, like post-operative cases of oligodendroglioma. You see the CT scan, you see only the post-operative changes in the frontal area of the brain, but you don't know whether there is a recurrence of the tumor or there is a residual tumor or the fibrosis. But when you do a FDG scan, you see there is besides the glucose being taken in the normal area of the brain, in the cortical gray matter, there is a very glucose-avid area in the medial part of the frontal lobe, which is coincides somewhere here, which we can see in the CT or MRI. It cannot be shown, and you see this is a very glucose uptake. So in a scenario, in a clinical scenario of the post-operative brain tumor, this can't be a inflammatory lesion, but a recurrence of the tumor. This is the FDG scan. Now we, as I said to you, the limitations of the FDG scan. Here, this is for my young colleagues here, this is a CT scan, this is a PET scan here, and this is the fused image. You see here a case of the low-grade glioma. You see these are all FDG scan and PET CT are completely normal. You hardly pick up any intracranial space occupying lesion. But when we subjected them to the DOPA, we found that the big large region which is sitting in the left parietal area. This patient was a case of seizures, and so we could see. So there are low-grade gliomas as a beside the delineation of the dopaminergic pathways, though we have to do a lot of histological correlation and what are the tumors which are having these kind of dopaminergic pathways. So still there was a lot of work to be done in due course of time, but we have found that the DOPA is very, very sensitive for the low-grade gliomas too, beside delineating the dopaminergic pathways in the brain. So as I said to you, there are some limitation of the FDG, because the FDG uptake that depends upon in a variety of the conditions which I have already told, and there are some non-tumorous conditions also like schwannomas and the metastasis, and the GBM also take less glucose. So how we can solve this problem with the molecular imaging? Here is another example of the users of the DOPA. You see here the post-operative patient, the normal FDG is normal, not showing any change. But when we have used the DOPA, you see there is a small recurrence of the tumor in this area. So this is again a case of the grade 2 glioma. There is a recurrence of the tumor in there is some sort of edema, the hyperintensity in the MR images, and which has been shown that the F-DOPA is being taken here. So this can be a recurrent tumor in the left thalamic glioma. Now coming to the new radio tracers, which I want to sensitize this August gathering, we, as I said, beside the F18, the fluorine compound, we in our institutions are making carbon-11 based compounds. The only problem with this, their half-life is only 20 minutes. So they have to be injected into the patient immediately, but they play a very, very important role because it is very, very sensitive and very, very specific to pick up the low as well as the high grade of the gliomas. And because the carbon-11 compound, methionine compound, is taken only by the neoplastic tissue where there is a cellular proliferation, there is a DNA duplication, because it is an amino acid transporter. It tells you about the protein synthesis, the turnover of the cellular membrane. So normal gray matter of the brain will not take carbon-11. So here is an example here. You see this is the post-operative patient of the MR. You see there is some CSF correction is there called post-operative changes, marked hyperintensity in the area of operated area. The multinuclear spectroscopy shows you the choline also very high. The choline is a compound which is found in the cellular membrane. It's very, very high. When we did the FDG PET scan, you see there is hardly any uptake, though it is being taken up by the other parts of the brain. But in the post-operative area of the brain, there is hardly any glucose uptake. So it is giving you a false positive outcome. But when we did the carbon methionine, there is certainly a recurrence of the tumor in these areas of the operation. So this is a very, very diagnostic. You see here, this compound has not been taken by the other parts of the brain. So beside this, we have got the several examples in the comparative in our institute. We have subjected all the patients with the FDG scan, then selected patients we have done with the carbon methionine, FLT, F-DOPA, where we can try, we wanted to establish the utility of these compounds in the complex scenarios. Here is again the example of a patient of the recurrent GBM. You see a very subtle subependymal recurrence of the tumor in a post-operative patient, which was not very confident with your MR. FDG scan has not shown it, but the carbon methionine has picked up as a lesion which is very, very avid on the showing you the tumor recurrence. Now coming to the another type, as I said target, now we are targeting the DNA, the nucleoside. As you all know, the DNA's importance in our day-to-day life, and here is a compound called the fluorolevothiamidine. It is one of the nucleosides. If you remember your first year physiology, anatomy and all that, you will be talking about the nucleoside. So here we are targeting on the nucleoside, and it is a very, very good marker of the cellular proliferation. It is very, very useful for pick up the early metabolic, early metastatic lesions from a variety of the ways here. Now here is an example of a CT, FDG scan and FLT. Post-operative patient, you see the CT and the FDG are completely unremarkable, but if you pick up with the FLT, the fluorolevothiamidine, there is a avid uptake of these radiotracer in this area of the brain, showing you a very, very early recurrence which can be surgically amenable. Because the biopsy, we have got a lot of stereotactic techniques nowadays. The surgeon also wants to know from where to take the biopsy. So these, the PET imaging not only playing a role in the diagnosis, but the biopsy of the tumor and the surgical treatment, because the neurosurgical techniques are advancing in a very fast pace. So imaging technologies also have to keep a space with them to facilitate and to do a corroborative work. Another case of the gliosarcoma you see here, there's a comparison between the contrast-enhanced CT, normal PET scan, PET CT scan, and carbon methionine and MISO. I want to introduce another compound here which is called MISO. MISO, methyl iso something, I'm forgetting at the moment. It is a metabolite which is mark of the hypoxia. Wherever there is a anaerobic glycolysis taking place in our body system, the MISO, F-MISO can pick up that anaerobic. In a neurological condition, it is important because the chemotherapy or radiotherapy, those tumors which are having anaerobic glycolysis, where there is an increase in the hypoxia, they do not respond to the radiotherapy or chemotherapy. So here I have shown you the utility of each radiotracer here. A post-operative patient of the brain gliosarcoma, the FDG scan picks up one or two hot spots showing you the increased glucose uptake in this tumorous area. But the carbon methionine picks up you the entire extent of the lesion beside, in addition to the very, very high uptake. So the tumor is involving a very large area of this lesion, and beside this, some of the part of the tumor is showing you the hypoxic changes also. Now another very, very sensitive radiotracer is the ethyl tyrosine, FET, fluoroethyl tyrosine. The F18 is the molecular probe, ethyl tyrosine is the conjugate, the biomolecule which has been conjugated. Just to recapitulate here, you see here another case of the high-grade glioma, though the FDG PET shows you some activity in this area beside the uptake in the normal brain gray matter. But here this is very, very selectively going to the tumorous area of the brain. The remaining part of the brain is completely normal. So these are the very selective, sensitive, specific radio tracer which are based on the various targets into the tumors, where a lot of research is to be done in the time to come, because the molecular imaging tells us that the tumor also have different kind of the targets. So possibly it will facilitate the further chemotherapy, radiotherapy and so on, but they pick up these kind of lesion very fast, because tyrosine is also, as I said, is an amino acid linked metabolite, so it also picks up the tumorous lesion in much better way. Now beside this, we have been practicing the MRI, the MRI beside the cross-sectional imaging, multinuclear spectroscopy has also can give you something about the cerebral metabolism, can tell you about the vascular flow, can tell us something about the metabolic processes going in a tumorous condition. I would like to again show you one of the example of the MR, how the novel techniques of the MRI can be exploited, because MR has got about 7 or 8 parameters as compared to CT, where only the attenuation coefficient is one of the parameters, how they can be exploited. So here is a case of brain tumor, which is the anaplastic oligodendroglioma on this pathology, but the problem here is the non-enhancing tumor. MR also sometimes, the tumor does not enhance. So whether it is a tumorous condition or not, whether it is benign or a malignant, or if it is a tumor, where is the perifocal edema is associated here. If the surgeon wants to do the stereotactic biopsy, from where he has to take the stereotactic biopsy. So these are some questions which are coming to the clinician's mind. So I will show you how the various techniques of the MR can also be used, which is indirectly a type of metabolic or the molecular imaging here. You can see here a T2 weighted image, T1 weighted image, and the T1. You see, there's hardly, and these are the post-contrast T1 weighted images. These are T2 weighted images. Now you see here, we can map the cerebral blood flow by perfusion MR technique. Here, this is the regional cerebral blood volume. This is the blood flow map. This is again the cerebral blood flow map. So it shows you that this particular region of this tumor is highly vascular. It has got a more flow of the blood as well as the more volume of the blood. The remaining of the brain tissue or the tumorous condition is associated with some sort of glial tissue, or it may be because of the peritumoral edema. So surgeon can take biopsy, stereotactic biopsy from these regions, and so this is somewhere in this area we see. If you combine these images, this is the tumorous area of the brain. So now how to confirm, because MR is also have a capability of one stage shopping. You can find out the blood flow, blood volume, but you can also quantify them, confirm them by their metabolic pattern. The same case when subjected, you see here, this is the cerebral blood flow. This is called the MRSI, the the MR spectroscopic imaging. We do a multi-voxel imaging, here the spectroscopy, and that is spectroscopy, that analytical various graphs are converted into by a image processing tool into a map like a nuclear medicine map you have seen here. So this, within this cerebral blood volume, there is an area of the tumorous condition which is very, very highly vascular. Red is the highest where there is a choline concentration. This is basically a choline creatinine map. In the brain, we have got the choline, creatinine, and we have got the N-acetyl aspartate. There are three main metabolites are there. So you see there is a choline creatinine map, because in the cellular proliferation, in the cellular multiplication, the choline content goes very high. So in this particular area, this is the map shows a very hot spot where the choline concentration is very, very high. So how to confirm it? We have done the spectroscopy from this area, and we found that the choline is persistently very, very high. So you can, this is an example where you can do a chemical analysis of the tumor, you can do the blood flow and cerebral blood flow. So it also tells you about the molecular imaging of a brain tumor, facilitates the stereotactic biopsy, can also facilitate these all techniques can be replicated in a post-operative scenario also. Now coming to the epilepsy, one of the very, very important case where there is the intractable epilepsy, the temporal lobe epilepsy, the focus is not seen in the majority of the cases. So the molecular imaging plays a very, very important role here. The 18-FDG you see in the left temporal area, there is hardly any activity in all the images. These are the colorful images are not from the PET scanner, they are analyzed. The PET images are analyzed because of the statistical parametric mapping. We quantify, because the quantification is the biggest problem we are trying to learn at our institute, to quantify the metabolite concentration. But here it's very obvious there is hardly any glucose uptake in the left temporal lobe. So this is the case of left temporal lobe epilepsy. As we are beginning, we are growing in the molecular imaging. Our institute is trying to make new radio tracers beside the FDG, which are selective, targeting different kinds of things. We are working in other systems also, like because of the paucity of time, we are working on the F-choline also, which is a very, very important radio tracer for the prostatic cancer, very, one of the #1 diagnostic tool available here, but only thing you have to make the radio tracer. So I don't want to take much of your time, but as far as the neurology is concerned, we are trying to also do the O15. This is a very new facility which we have installed in our center. It is the oxygen utilization while doing a task. What is the differential oxygen utilization by the brain? We have told you about the glucose metabolism. Here we are trying to tell you about the oxygen utilization, like a functional MRI with the help of the O15. You see here This is the normal phase and the oxygen is being taken by the gray matter. While doing a particular task, the motor area is getting activated, showing you the more oxygen utilization. We are also trying to do comparison between the functional MRI and the PET functional MRI, doing a variety of the stimulation. During the visual stimulation, you see here the visual cortex is getting highlighted with the functional MRI, and the output is more or less same with the PET imaging. So friends, I won't take much of your time. I just want to conclude my talk. This is a new era of molecular imaging by which we can unravel the various cellular and the metabolic processes at a very, very early stage, so that we can detect them, delineate them, quantify different metabolites, and do the therapeutic intervention and facilitate the patient treatment. Thank you very much for the patient hearing.